thrombocytopenia. Normal hemostasis is described more fully in Chapter 30. It involves the vascular endothelium, platelets, and coagulation factors, which function together to stop hemorrhage and repair vascular injury. A disruption of any of the components may result in bleeding or thrombotic disorders. This is a graphic depicting normal hemostasis, showing the extrinsic and intrinsic pathways. Thrombocytopenia is a reduction of platelets below 150,000. Acute, severe, or prolonged decreases from this normal range can result in abnormal hemostasis that manifests as prolonged bleeding from minor trauma to spontaneous bleeding without injury. Platelet disorders can be inherited, but the vast majority are acquired. A common cause of acquired disorders is the ingestion of certain herbs or drugs. Although some agents are directly myelosuppressive, such as chemotherapy, the usual mechanism of thrombocytopenia caused by herbs or drugs is accelerated platelet destruction caused by drug-dependent antibodies. Antibodies attack the platelets when the offending agent binds to the platelet surface. The causes of acquired disorders include autoimmune diseases, increased platelet consumption, splenomegaly, marrow suppression, and bone marrow failure. A careful review of the patient's history helps to identify the cause of thrombocytopenia. For example, quinine is in tonic water and in many herbal preparations. In addition, some drugs can affect platelet aggregation. Aspirin doses as low as 81 milligrams can alter platelet aggregation. Normal function is restored when new platelets are formed. RH is a 46-year-old cancer survivor who returns to your clinic for a regular checkup. She is currently reporting an increase in fatigue for the last 2 or 3 weeks. She's also unable to complete her normal morning ADLs without intermittent periods of rest. What should you do first? Well, you should complete your nursing assessment with particular attention to the vital signs, checking for fever, tachycardia, and hypotension. Question carefully about any overt or covert symptoms of bleeding. Do a complete medication assessment, including over-the-counter medications. And question more thoroughly her symptoms of pain, stool color, bleeding gums, changes in menses, vomiting blood, easy bruising, headaches, or bloody urination. Thrombocytopenia can be either inherited or acquired. Acquired types of thrombocytopenia include immune thrombocytopenic purpura, ITP, thrombotic thrombocytopenic purpura, or TTP, or heparin-induced thrombocytopenia, HIT. The most common acquired thrombocytopenia is a syndrome of abnormal destruction and reduced production of circulating platelets termed immune thrombocytopenic purpura, or ITP. It was originally termed idiopathic thrombocytopenic purpura because its cause was unknown. However, it's now known that ITP is primarily an autoimmune disease. In ITP, platelets are coated with antibodies. Although these platelets function normally, when they reach the spleen, the antibody-coated platelets are recognized as foreign and are destroyed by macrophages. Decreased platelet production contributes to ITP. Sometimes infection such as Helicobacter pylori or viral infection contributes to this disorder. Platelets normally last between 8 and 10 days. However, in ITP, survival of platelets is shortened. The clinical syndrome manifests as an acute condition in children and a chronic condition in adults. Chronic ITP may occur in women between 15 and 40 years of age or older. Chronic ITP has a gradual onset and transient remissions may occur. Multiple therapies are used to manage the patient with ITP, such as corticosteroids, splenectomy, immunosuppressants, or thrombopoietin receptor agonists. TTP is an uncommon syndrome characterized by hemolytic anemia, thrombocytopenia, neurologic abnormalities, fever in the absence of infection, and renal abnormalities. Not all features are always present in all patients. The microthrombi deposit in arterioles and capillaries. TTP, in most cases, is due to a deficiency of a plasma enzyme, ADAMTS13, that usually breaks down the von Willebrand clotting factor, or VWF, into normal size. VWF is the most important protein-mediating platelet adhesion to damaged endothelial cells. Without the enzyme, unusually large amounts of VWF attach to activated platelets, thereby promoting platelet aggregation. TTP has a slight female predominance. The syndrome may be idiopathic, thought to be due to an autoimmune disorder against ADAMTS13, but may be due to certain drug toxicities, for example, chemotherapy, cyclosporin, quinine, oral contraceptives, valacyclovir or Valtrex, clopidogrel or Plavix, pregnancy, preeclampsia, infection, or the result of the known autoimmune disorder such as lupus or scleroderma. TTP is a medical emergency because bleeding and clotting occur simultaneously. One of the risks associated with the broad and increasing use of heparin is the development of the life-threatening condition called HIT. It's also called heparin-induced thrombocytopenia and thrombosis syndrome, or HITTS. In HIT, platelet destruction and vascular endothelial injury are the two major responses to an immune-mediated response to heparin. Platelet factor 4, PF4, binds to heparin. This protein is made and released by platelets. This complex then binds to the platelet surface, leading to further platelet activation and release of more PF4, thus creating a positive feedback loop. Antibodies are created against this complex, and they are removed prematurely from circulation, leading to thrombocytopenia and platelet fibrin thrombi. Platelet aggregation also induces heparin to be neutralized. Thus, more heparin is required to maintain therapeutic activated partial thromboplastin times. Heparin must be discontinued when HIT is first recognized, which is usually if the patient's platelet count has fallen 50% or more from its baseline, or if a thrombus forms while the patient is on heparin therapy. As many as 5% of patients on heparin therapy develop HIT. Additional complications may include arterial vascular infarcts resulting in skin necrosis, stroke, and end organ damage, such as the kidneys. Symptoms of bleeding are unusual because the platelet count rarely drops below 60,000. In thrombocytopenia, patients are often asymptomatic. The most common symptom is mucosal or cutaneous bleeding. Mucosal bleeding may manifest as epistaxis and gingival bleeding, and large bullous hemorrhages may appear on the buccal mucosa because of the lack of vessel protection by the submucosal tissue. Bleeding into the skin is manifested as petechiae, purpura, or superficial ecchymosis. Petechiae are small, flat, pinpoint red or reddish-brown microhemorrhages. When the platelet count is low, red blood cells may leak out of the blood vessels and into the skin to cause petechiae. When petechiae are numerous, the resulting reddish skin bruise is called purpura. Larger purplish lesions caused by hemorrhage are termed ecchymosis. Ecchymoses may be flat or raised, painful and tenderness is sometimes present. Hemorrhage may occur in any area of the body, including the joints, retina, and brain. Cerebral hemorrhage may be fatal. Insidious hemorrhage may first be detected by discovering the anemia that accompanies blood loss. Because thrombocytopenia can be accompanied by vascular thrombosis in some of these disorders, signs and symptoms of vascular ischemic problems can manifest. For more information, see Chapter 38. So, for example, subtle confusion, headache, or even serious manifestations such as seizures and coma due to TTP-related thrombosis may be seen. Because signs and symptoms may be subtle, astute and thorough assessment of the patient is essential. The diagnostic studies necessary include platelet counts, blood smears, a medical history, clinical examination, and lab parameter comparisons. Any reduction in platelets below 150,000 may be termed thrombocytopenia. Prolonged bleeding from trauma or injury does not usually occur until platelet counts are less than 50,000. When the count drops below 20,000, spontaneous life-threatening hemorrhages such as intracranial bleeding can occur. Platelet transfusions are generally not recommended until the count is below 10,000, unless the patient is actively bleeding. Examination of the peripheral blood smear may help distinguish acquired disorders such as ITP and TTP from congenital disorders, which may be indicated by abnormally sized platelets. The patient's medical history and clinical examination, along with the comparisons of laboratory parameters, help to determine the etiology of the thrombocytopenia. Table 3113 compares different types of thrombocytopenia. Laboratory tests that assess secondary hemostasis or coagulation, such as the prothrombin time and activated partial thromboplastin time, or APTT, can be normal even if in severe thrombocytopenia. If they are elevated, this may point towards disseminated intravascular coagulation. Specific assays such as ITP antigen-specific assay, C-serotonin release assay, or enzyme-linked immunoassay, or ELISA, for PF4 heparin complex for HIT can be done to assist with the diagnosis. In TTP, testing for deficiency of ADAMTS13 is not always diagnostic, so an increase of lactic dehydrogenase, or LDH, may help establish the diagnosis. When thrombocytopenia occurs with anemia characterized by altered red blood cell morphology, including spherocytes, fragmented cells, and pronounced reticulocytosis, a diagnosis of TTP should be suspected. These findings are partially a result of intravascular fibrin deposition causing a slicing of RBCs. In TTP, thrombocytopenia may be severe, but coagulation studies are normal. Bone marrow examination is done to rule out production problems as the cause of thrombocytopenia, such as leukemia, aplastic anemia, or other myeloproliferative disorders. Bone marrow analysis is performed if other tests are inconclusive, especially in older patients because of the higher suspicion of an underlying bone marrow disorder. When destruction of circulating platelets is the etiology, bone marrow analysis shows megakaryocytes, which are the precursors of platelets, to be normal or increased, even though circulating platelets are reduced. The absence or decreased number of megakaryocytes on bone marrow biopsy is consistent with thrombocytopenia caused by decreased bone marrow production, that is, aplastic anemia. Special blood analyses using flow cytometry and other techniques can detect antiplatelet antibodies as a source of destruction. When taking her blood pressure, you notice RH has small, flat, pinpoint reddish-brown microhemorrhages all over her forearms. On further inspection, you notice that on her left thigh she has a very large purple bruise, which she reports as tender to the touch. What are these clinical manifestations called? The first is petechiae, and the second is ecchymosis. Collaborative care is based on the etiology of the disorder. Removal or treatment of the underlying cause, or whatever the disorder is, may be sufficient. Avoid aspirin and other medications that affect platelet function or production. In ITP, therapy is initiated if the platelets are below 30,000. There are multiple therapies used to manage the patient with ITP. If the patient is symptomatic, treatment may be started earlier. Corticosteroids suppress the phagocytic response of splenic macrophages, resulting in increased lifespan of platelets. Corticosteroids depress antibody formation and reduce capillary leakage. Anti-RHOD, or anti-D or WinRho, is a component of IVIG. IVIG and anti-Rho may be used in the patient who is unresponsive to corticosteroids or splenectomy, or for whom splenectomy is not an option. In collaborative care, splenectomy is indicated if patients do not respond to other treatments. It can be done laparoscopically, and in 60 to 70% of the patients, it will achieve complete or partial remission. The effectiveness of splenectomy is based on the fact that the spleen contains macrophages that sequester and destroy platelets. Structural features enhance antibody-coated platelets and macrophage interaction. The effectiveness of splenectomy is also based on the fact that some antibody synthesis occurs in the spleen and antiplatelet antibodies decrease after splenectomy. The spleen normally sequesters about a third of the platelets, so its removal increases the number of platelets in circulation. Romiplastim, or Nplate, and eltrombopag, or Promacta, are used for patients with chronic ITP who have had an insufficient response to other treatments or who have a contraindication to splenectomy. These drugs are thrombopoietin receptor agonists, thus increasing platelet production. Danazol, or Danacrin, an androgen, may be used along with corticosteroids in some patients. Although the mechanism is not totally understood, danazol increases CD4 T cells, thereby decreasing the immune response. Immunosuppressive therapy may be used in refractory cases. Platelet transfusions are used to increase platelet counts in life-threatening hemorrhage. They should never be used prophylactically because of antibody formation. They are indicated for a platelet count less than 10,000 or if bleeding is anticipated before a procedure. Aminocaproic acid, or Amicar, an antifibrinolytic agent, may be used for severe bleeding. The first thing to treat is the underlying disorder, or to remove the cause. Untreated TTP usually results in irreversible renal failure and death. Plasmapheresis is used to aggressively reverse platelet consumption by supplying the appropriate VWF and enzyme ADAMTS13 and removing the large VWF molecules that bind with platelets. Corticosteroids may be added to this treatment. You'll also find information about this in Chapter 14. Recently, rituximab, or Rituxan, has been used. Other immunosuppressants such as cyclosporine or cyclophosphamide Cytoxan may also be used. Splenectomy may be considered when patients are refractory to plasma exchange or immunosuppression. The administration of platelets is generally contraindicated because this may lead to a new VWF platelet complex and increased clotting. RH's lab results are back. The platelet count is 40,000. H&H is 9.9 and 29. Red blood cells is 3.26. PT is 15 seconds. Activated PTT is 35 seconds. What type of thrombocytopenia does she probably have? That would be thrombotic thrombocytopenic purpura. Let's talk for a moment about heparin-induced thrombocytopenia. Permanently stop all heparin, including heparin flushes. Note this clearly on the medical record. Start the patient on a direct thrombin inhibitor. This will maintain anticoagulation. A direct thrombin inhibitor such as lepyridine, argatroban, fondaparinone, which is Erixtra, may also be used. Coumadin should only be started when the platelet count has reached 150,000. Patients who have had HIT should never be given heparin or low molecular weight heparin. This should be clearly marked on the patient's medical record. For severe clotting, plasmapheresis to clear the platelet aggregating IgG from the blood is used. Protamine sulfate will interrupt the circulating heparin. Thrombotic agents will treat the thromboembolic events, and surgery will be needed to remove clots. Platelet transfusions are not effective because they may enhance thromboembolic events. Acquired thrombocytopenia from decreased platelet production is also an issue. Collaborative care would include care based on identifying the cause and treating the disease or removing the causative agent. Treat it with corticosteroids if the precipitating factor is not known. Platelet transfusions are used for life-threatening hemorrhage. Often, this is caused by another underlying condition or the therapy used to treat another problem. For example, in acute leukemia, all blood cell types may be depressed. Chemotherapeutic drugs can cause bone marrow suppression. Thrombocytopenia will resolve as patient is adequately supported during treatment. So what kind of treatment should RH expect? What could happen if she doesn't follow through with her treatment, and how will her doctor know when to stop her treatment? Well, first, the type of treatment she should expect is that the underlying disorder would be treated, or the causative agent will be removed if possible. A plasma exchange or plasmapheresis would be started to aggressively reverse platelet consumption. If she didn't follow through with treatment, there could be irreversible renal failure and death. And her doctor will know when to stop the treatment when the platelet count normalizes and hemolysis ceases. For your nursing assessment, you would collect subjective data including past health history, medications, and functional health patterns, and for your objective data, look for fever, lethargy, bleeding, splenomegaly, abdominal distension, and look at laboratory data. Possible diagnostic findings include platelet counts below 150,000, prolonged bleeding times, decreased H&H, normal or increased megakaryocytes in bone marrow examination. You should also take a look at Table 3115. Your nursing diagnoses would include impaired oral mucous membrane related to low platelet counts and or effects of pathologic conditions and treatment, risk for bleeding related to decreased platelets, or deficient knowledge related to lack of information regarding the disease process and treatment. Your overall goals will be that the patient will have no gross or occult bleeding, will maintain vascular integrity, and will manage home care to prevent any complications related to an increased risk for bleeding. For implementation in health promotion, you'll discourage excessive use of over-the-counter medications, especially aspirin products. Encourage the patients to seek prompt treatment for any symptoms of bleeding. Vigilant nursing care for patients receiving cancer chemotherapy drugs is important. Many medications contain aspirin as an ingredient. Aspirin reduces platelet adhesiveness, thus contributing to bleeding. For acute intervention, you would prevent or control hemorrhage, understanding that bleeding usually begins superficially. Any bleeding needs evaluation and treatment, and you need to watch for bleeding that can be difficult to detect. Deep bleeding into muscles, joints, and abdomen usually occurs only when clotting factors are diminished. Emphasize that a seemingly minor nosebleed or new petechiae may indicate potential hemorrhage, and the healthcare provider should be notified. Bleeding from the posterior nasopharynx may be difficult to detect because the blood may be swallowed. Additionally, you want to avoid IM injections. If subcutaneous injection is unavoidable, use a very small gauge needle and afterwards apply pressure and or ice packs. And teach self-care measures to reduce the risks that would cause bleeding. Also, for acute intervention, you would closely monitor certain lab tests and manage blood loss from excessive menstrual bleeding. Note that many of these disorders may be accompanied by vascular clotting, and appropriate assessment and management should be taken. See Chapter 38. Note that as bleeding occurs, red cell and coagulation factors are consumed along with platelets, so it's important to monitor all blood cell and coagulation studies. In a woman with thrombocytopenia, menstrual blood loss may exceed the usual amount and duration. Counting sanitary napkins used during menses is another important intervention to detect excessive blood loss. Blood loss of 50 milliliters will completely soak a sanitary napkin. Suppression of menses with hormonal agents may be indicated during predictable periods of thrombocytopenia to reduce blood loss from menses, such as during chemotherapy or hematopoietic stem cell transplantation. You may find yourself administering platelet transfusions, but this should only be a temporary measure until the underlying problem is resolved. It should only be used if absolutely necessary because transfusions can be hazardous. Many therapeutic and surgical procedures depend on blood product support. Avoid developing a complacent attitude about this common but potentially dangerous therapy. Make sure that the physician has discussed the risks, benefits, and alternatives to blood transfusion with the patient, and that this is documented in the patient's medical record. Traditionally, the term blood transfusion meant the administration of whole blood. Blood transfusion now has a broader meaning because of the ability to administer specific components of blood such as platelets, packed red blood cells, or plasma. Usually, a specific component is ordered, although whole blood may be rarely used with massive hemorrhage or foreign exchange transfusion. Teach the person with acquired thrombocytopenia to avoid causative agents when possible. There's a table that gives you this information, 3112. If the causative agent cannot be avoided, such as chemotherapy, teach the patient to avoid injury or trauma during these periods and to be aware of clinical signs and symptoms of bleeding caused by thrombocytopenia. This would be listed in Table 3116. Patients with either ITP or acquired thrombocytopenia should have planned periodic medical evaluations to assess their status. These regular evaluations can be used to assess the treatment situations in which exacerbations and bleeding are likely to occur. The impact of either an acute or chronic condition on the patient's quality of life should also be addressed appropriately. For evaluation, your expected outcomes include no evidence of bleeding or bruising and the patient's ability to verbalize required knowledge and skills to manage their disease process at home. If RH does not respond to plasmapheresis, what surgery might be done? And what is your role in preparing her for care after surgery? If plasmapheresis is not successful, the surgery would be a splenectomy because it's a major site of autoantibody production. And you would monitor patients for their response to therapy, teach avoidance of causative agents, trauma, and injury, teach clinical signs and symptoms of bleeding, encourage regular medical exams, and manage quality of life issues.